if you like to start for the second talk, because I have a lot of questions here. Do you see?
Good.
So I know.
We
Yeah.
we should try to address all of them. But the second part, I made it a little smaller now because talking about keratoconus treatment today, it is a new specialty. Is a topic for a whole course, maybe a whole postgrad, and but we have to understand some basic concepts, which is the paradigms and paradoxes. We broke the paradigm that lays the transplant will be the only surgery. Now we have cross-linking, we have surface ablation, we have rings, we have phakic IOLs, and the paradox is that when you need surgery, you should do it as soon as possible. But when you don't need surgery, you should really reconsider if surgery should be done. So the paradox is don't do it if you don't need to do it, but do as soon as possible if you need it. So the question is simple: when you need it. You need surgery when the patient is progressing, the disease is getting worse, and that's very important because we should see the progression or the high chances of progression. And of course, when surgery is indicated is because the patient is not seeing well. So that's easy. I'm not seeing well and you need some help. But when the patient is seeing well, you have to consider if the surgery is going to help or harm the patient the most. I like always to give the information to people not to rub the eye. Clinical treatment of keratoconus starts with patient education and education about the disease, about the condition, control allergy, tell people not to rub the eye. This is a eye rub video from YouTube, and some things that should be thought about considering is riboflavin rich diet, maybe drops, other treatments to improve the natural cross-linking. But stop eye rubbing is universally, actually, is one of the things that were acknowledged by 100% of panelists in the consensus. So important of eye rubbing, and the disease should be considering not rub the eye. Managing ectasia prior to keratoplasty is a very interesting topic. We have a review paper published a few years ago. This is something we have to understand if it's progressive or not, the good vision, bad vision, and understand when we should do epi-on cross-linking, when we should do cross-linking in patients with good vision. And this is something to be understood in the algorithm when the surgery is elective, and that's pretty much based on the paradoxes. Ectasia is not refractive surgery when we do surgery for ectasia, and I like this Bart Simpson concept that a lot of refractive surgeons attempt to do surgery elective for those patients, and we should reconsider if it's necessary or not. And based on that, we wrote an editorial in the Brazilian Journal of Ophthalmology that therapeutic surgery is not the same as refractive elective procedure, and the goal is the same. It's not the same. And understanding the goal, you get more chances for being happy after surgery. And I always quote the consideration of the genetic similarity between the lion and the cat. And if you want to consider the genetic similarity here and you confuse both, you may get in big trouble. And that's pretty much when you consider doing refractive surgery as an elective procedure, you can get in big trouble. Corneal collagen cross-linking, not collagen anymore, it's just collagen was the first designation. And Professor Seiler with his group, you have Eberhard Sperl, you have Wallenstack, and the group back in Germany before he moved to Zurich started the cross-linking, and we developed tremendously. A few years ago, there was a great book edited by Hafezi and Runderman, and the controversial points I was asked to write about, defining the progress before doing cross-linking, and there was no opposite to that. It was just, there was a controversy without a controversial rebuttal. And we included this case presentation, a patient with 17 years old that presented with low vision in the left eye, 2000 corrected to 2030, 2020 uncorrected in the right eye. Unquestionable keratoconus is not a very asymmetric ectasia with a normal topography eye. It's a very asymmetric ectasia, but with abnormal TKC, abnormal topography. That's when we say topography gives you the sensitivity to detect abnormality, but not enough to say you need surgery also in the right eye. So you need surgery in the left eye, and the patient was concerned because some people would have said, some colleagues would have said, for the patient to have cross-linking in the right eye and do nothing in the left eye but a transplant. So imagine if the patient has a cross-linking, epi-off cross-linking in the right eye, the patient will come to your clinic with a bad vision in the left eye and good vision in the right eye. And then you treat the patient, and now the patient has pain and bad vision in the right eye and still bad vision in the left eye. I have seen that many times. I'm not saying that surgery is never indicated in the right eye of patients like that, but should be considered carefully. What we did is the corneal ring in the left eye, not a transplant for sure. Transplant is the least, it's not the worst, it's not a bad, but it's the least option for these patients. And this patient got stable since the 3 months post-op, and we have seen him every year. And the last follow-up was last year, probably after the coronavirus, he will come back. He always comes in the first few months in every year, and he's still stable. And we published the cohort in 4 years. Now we have 10 years follow-up roughly for this case. The problem is this. See this case. The patient has Down syndrome, 19 years old. He presented with a very bad vision in the right eye, still seeing relatively well in the left eye. I told the patient, let's do cross-linking, let's do the procedure. The family was not happy with that, and they did not do the surgery. So it was March 17, and you see what happened. It's one of the highest progressions that we see. It's 17 to 19, you see 71 diopters to 100 diopters and 51 to 75. And you see how high progressive these patients can be. So in this situation, we missed the opportunity to do the cross-linking. And it was not because I did not do it. It's because the parents were scared because of the general anesthesia and all these difficulties. And I know my colleague, Farah Hafezi, with his wife, Nikki Hafezi, they have a 21 light for sight, which was something I told them we can get funding even for doing the procedure without cost. And the patient, the family did not want to do the surgery. So it came back a couple years later, and you see the progression. And even though in 2019, when I said and I showed them this, we should do the procedure in the left eye, they still decided not to do it. At least they didn't do it with me. Maybe they have done somewhere else, but it's something that we lose the opportunity. And you see, the best way of monitoring the progression is with the ABCD, actually ABC from Michael Bell, which is front and back surface elevation at the thinnest point and the curvature. The C is the thickness in the thinnest point, corneal thickness, and the D is vision. So you don't need to have that nice fancy software for detecting ectasia progression. And you can see the biomechanical weakening of the cornea. So the cornea really progressed in terms of cross-linking. And we are learning now how to identify a patient that progressed and compare to a patient that did not progress. And eventually beyond screening, diagnosing, and staging is prognosing, so that we can work with a safe early detection and early indication of the patient that would benefit from surgery. We did a study on 50 patients that I only did surgery in one eye. So I had my colleague from Portugal visiting me as a resident, very good resident, Diogo Lopes, from Portugal, from Lisbon. And he came and he was very eager to do research. And I told him, let's do this research. So he collected the patients that had surgery only in one eye. And the fellow eye was not treated, at least at that time that he did the study. So he looked at the operated eye, and we saw an improvement in uncorrected and distance correct vision, reducing the astigmatism. And the non-operated eye, there was also an improvement. You see an improvement here in the distance correct vision and the uncorrected vision. That's because the patient treated the ocular surface, stopped eye rubbing, and some of them improve. And eventually that's statistically significant. And we did not have a problem that they should do surgery in not everybody. So the importance of that is that when we consider indication for the cross-linking, is not to do cross-linking in every keratoconus patient regardless of age. That's a major message here. I'm not saying that we should not do cross-linking. We should do cross-linking when needed. That's the paradox. When needed, as soon as possible. But when you don't need, you may harm the patient, and eventually every case should be understood properly so that you can make a clinical decision. So in conclusion, surgery is not indicated for every case. Avoiding eye rubbing and sleeping over in the eye is also very important. It's part of the clinical education in our campaign, the Violet June campaign, which I highly count with colleagues like you and all colleagues from Egypt to promote that. In June 2020 will be a very special June because we'll be over the virus pandemic, and we will have the message for not rubbing the eye even more important, because you have to wash your hands and not rubbing the eye.
Yes.
And that will be very important.
Yeah, it's a combined
And
message. Wash your hand,
yeah,
and don't rub your eye at the same time for the coronavirus and for the corneas together.
yes, it's an enhanced message. That's the enhanced Violet June campaign. So close follow-up is important with objective data, and the Bell-in ABC and D, which is vision, is very important. Cross-linking indicated when there is a progression, and if there is progression, should do it as soon as possible. We need prognostic factors, and we have ectasia and keratoconus as being possibly separated if you understand properly. Just last word on that concept is that every keratoconus is an ectasia, but not every ectasia is keratoconus. So ectasia may be due to the environment, and eventually those patients that have environmental ectasia, those are the easier to treat, because if you stop the environmental condition, they may get better by themselves. Some of the cases with a true genetic keratoconus, let's say, those are the patients that they need surgery as soon as possible. So this prognostic factor will be very important for kids like the one I shown. And eventually you cannot obligate the patient to do the surgery, but advise properly. And eventually when I advise, I remember when I saw the progression of that patient, I was very sad, because eventually I told the patient to come back in a couple months, and the patient could not come back, and come back in 2 years with a huge progression. So I failed myself. And even though I would not be convinced that that case will be a indicator for doing cross-linking in everybody, which will be excellent for my clinic, by the way. And eventually trying to get a prognostic factor for being more emphatic for the patient family, so that they should understand when to do the surgery. And cross-linking is a very good procedure. Excellent. It's a deserving Nobel Award for the group that started, led by Professor Seiler, but it's not something for every patient. So inviting again you all for the Violet June campaign. We have a book on Keratoconus that was kindly translated to
Arabic language.
Arabic language by my friend Professor Mohammed Shafiq,
Yes.
and I'm sure that this will be a very good help for patients that should understand about the disease and how to make a decision properly. So this is my two little girls. They are here looking at me and here showing the book to you. So thank you very much for your attention and opportunity to share, and I'm happy to try to answer any questions.
Really, I thank you so much, Professor Renato, for uh, great presentations about very crucial and very really, I want to give it the right expression. It is it's confusing. It's confusing problems in the cornea, for the cornea and for the refractive surgeons, especially. But actually, we are following the printing of the Arabic translated book for the Violet June. But you know, now everything is stopped. But we are following and proceeding in that. The last week I was talking about the Keratoconus, and I put many slides about the rubbing, the eye rubbing, and the Violet June, and your guiding campaign about that. And put the Violet June, the image you have sent to me with your honoring photo beside about that.
Thank you.
Actually,
Post it on social media.
yeah, okay, I'm preparing for all of that, but actually I found that most of the young ophthalmologists in Egypt and everywhere, it doesn't pay attention to the eye rubbing. Even themselves, they are rubbing their eyes. Don't know about it.
I don't rub the eye, doctor.
Yeah.
I don't rub the eye. That's a common day at the clinic. I don't rub the eye. The patient is rubbing in front of you, and I say, I just saw you rubbing your eye 2 times or more just in this 5 minutes that you are here.
Yeah.
And that's very interesting because they deny.
Yeah. Really, it's the truth. But actually, mostly you are the first one to take the minds to this problem, which was considered in the textbooks as just mild risk factors for keratoconus. I was booking a big note or a small book about the keratoconus. I found when I searched about on Google about the rubbing eye, I found very limited publications about this point, and all of them refer to the rubbing of the eye as a very mild risk factor, which is not proved to be a factor for the keratoconus. But nowadays, you are saying in a loud voice, the ectasia could be genetic, which is keratoconus, and could be environmental and mechanical, which is the rubbing, the eye rubbing. After your search and your the facts you have shown, this is about this point. About the second one of keratoconus and the cross-linking. If you feel that you have a problem with this patient in the follow-up, if you are treating patient who is not stable, he is not staying in the same place you are in, or coming to you from other country, like in Egypt, we have been receiving all the time patients from Saudi Arabia, from the Middle East, from everywhere, who may come to us for refractive surgery, to do a LASIK surgery. And we, on examination, we detected that these patients are keratoconus, especially in the early stages. If we said to the patient, go back to your country and you have to follow up with me or with any other eye doctor there in your country, I'm not sure that they will follow that, will respect that. Even we are finding our patients who are neighboring to us. When I tell this patient to come to me after 6 months, I find that this patient may come to me after 3 years with a worsening of the problem, with the advancement of the keratoconus. So I respect that. I respect that totally, but I want to pay to get to know about the compliance of the patient. Am not sure, if I'm not sure about the compliance of my patient regarding the follow-up, the regular follow-up, can I go for cross-linking with that patient?
Well, I'm not in a position to say you can do that, you should not do that. I'm not the, some people come with a concept that I'm the police. I'm like the judge for when to do cross-linking or not. I don't have that position.
Yeah,
That's not my, it's not under my power, not even my capacity for that. But first I want to address one thing that's very important, that we should acknowledge what has been done before us. And of course, since ever, cross-linking was very important. Eye rubbing was very important.
yeah,
So I want to share you, these are two important people that has done tremendously. Now, currently, we have Damien Gatinel with his defeat keratoconus concept, and Damien Gatinel with his team in Paris. Um, he has done tremendously great work in many areas, including keratoconus. But his point is that if you have keratoconus, it's always related to eye rubbing. It's a sine qua non, which is something that I really don't think it's correct. But eventually, it's still margin for debate and controversy, which I love to learn and discuss because that's how we evolve. And second, a few years back, this is 2009, Alan Carlson from North Carolina, he published a very nice article about keratoconus and eye rubbing, which time to rewrite the textbooks. And this was published in a not non-peer reviewed, the review of ophthalmology. And he even talked about, you know, rings and how to rub the eye badly and how eventually you should eventually consider to rub the eye and sleeping over the eye, which will be something that will be very harmful as well. So it's not something that I started. There are some papers on that. Even in the International Journal of Keratoconus, there is a review on eye rubbing, and it's very important that we understand uh, that eye rubbing is very bad. And I don't want to claim that I started that. But going back to the question, you know, we are at home. I think the whole world is at home.
yes,
The economy of the world is changing forever because of the coronavirus. We know that the coronavirus, it's literature. It's not something I think. It's, we know that 80% of people will not even get sick with the coronavirus.
yes,
And we all stopped going out to stay at home. We
yeah,
know some cases of, you know, young people that get sick, young people that can die because of coronavirus, but it's very rare.
yeah,
So when we, and I think we should stay at home, eventually reconsidering when to go back to our lives.
yeah,
And we have to plan that. And I believe the authorities all over the world, with all the issues economically, politically, that are happening everywhere, we see that on TV, the, that diverge from the main problem. But my point is that we are treating everybody to stay at home and change the whole economy of the globe because of the small percentage of people that can get really sick And
Yeah.
if they all get sick at the same time, it will be a very bad thing for the public health system, for the health system, even the private system. We
Yes.
don't have enough beds with intensive care units to take care of everybody. So we have to flatten the curve instead of having a huge
Yes.
peak, and we have to flatten the curve. So we always stay at home. But what is the harm for the whole globe economically to stay at home,
Yes.
considering the benefit of not having a collapse in the health system? So we are thinking it's a good thing. We should stay at home. But eventually, I would say we have to balance the medicine and the poison.
Yes.
So when you say a cross-linking should be indicated for a patient like you, let's go back, start diverging from our conversation, but that's something to think about when we think about pros and cons of anything. If you have a patient that you see, like that Down syndrome patient that I presented to you, that has a very high susceptibility or risk for progression, we should do it as soon as possible. Actually, that patient was already indicated. The patient was not seeing well, and the patient had an advanced keratoconus. So I told them you should do surgery as soon as possible already when I saw the first time in 2017. But when you say the cross-linking should be indicated to everybody, I see some overuse of the cross-linking as a procedure that is very good for the financial of the clinic that is doing cross-linking in everybody, but
Yes.
not necessarily very good for the patients that are receiving it. So if you ever want to do cross-linking, you have to be conscious. The decision, I always say that, the decision is always correct to do or not to do it if you make the decision with a conscious mind, understanding why you're doing it or eventually you're not doing it. It's like staying at home is correct, yes. Stay at home is very bad, yes. But
Yes.
we have to balance everything and eventually do a decision how and when
Yes,
as
sir.
soon as
Yes, sir.
possible.
I got the point. But, you mean that it is not for globalization of the decision. It's in the individualized decision for the doctor and for the patient. Yeah. The second question, and I need just two words of in your answer. When you find a child with Keratoconus or with ectasia, to be correct, to be correct name, ectasia in patient with VKC, Bernard keratoconjunctivitis, with the same problem of eye rubbing, and I found this child who is just 8 years old, 8 or 9 years old, and I found ectasia. To do cross linking for this child at the presentation time, at the time of presentation, or to follow.
Well, I have cases like that, and I would say, going back to the thing, keratoconus and ectasia, I think those cases mostly they have ectasia. So if you stop the environmental problem, you would be treating the disease. So these patients, they have to treat the allergy. And if you see the complications of cross-linking, if you have a patient with a very bad allergy condition systemically,
Yeah.
they may be at higher risk for having a epithelial defect that doesn't heal after surgery.
Yes.
So treat the condition first. And of course, you can do cross-linking as soon as the condition is treated if you think it's necessary. Of course, I don't have the power to say it's correct or not correct, but base your decision in a good judgment. And also not only good judgment, which I believe it's important to have complementary exams, you have documentation, everything, but also patient education. So the whole scope for the Violet June is public awareness.
Yes.
So I love when I see a patient that has read some of my articles and they come with a conscious mind, doctor, I understand that I have the disease and I'm here to say, if you think it's something to be done, we can do it. But, and they come with a proactive understanding. We have to, we live in a society that has legal issues, so we have to make a clinical education as part of our protocols for the consents.
Yes, sir.
So the patient has to understand and agree. So going back to your patient with allergic conjunctivitis, I would say do oral supplementation with omega-3, treat with artificial tears without preservative, start with steroids, topical steroids, and do a fast tapering, and keep them on tacrolimus. Tacrolimus. Do you have tacrolimus in your?
No, unfortunately, no. Tacrolimus, no.
Tacrolimus is a immune modulator.
Modulator.
I can send you some literature, and we have a local ophthalmic pharmacy in Brazil that puts it together in a drop.
Yes.
Used to be just in ointment, was much harder to prescribe because it was not so friendly for the patient. But the ointment was very effective already, but the drop is even better, and it changes the life of the patient. It changes, oral antibiotics, tetracycline and derivatives can help these patients. Multidisciplinary approach with, the pediatrician to treat the allergy, the atopy. Sometimes this patient have asthma. Psychological support is very important for these kids.
Yes.
So it's not only a cross-linking decision. It's a whole patient. And then I love when I remember my old professors in medical school when they said, "You're not treating the disease, you're treating a patient. It's not the right eye or the right cornea. It's the whole." Actually, sometimes the whole family. The whole family. It's
Yes.
not only the patients. The whole family that are sick together because of the cross-linking. And that's sometimes the decision, for example, that going back to that Down syndrome patient, the decision not to treat was based on the conscious decision. I remember the father and the mother say, "Doctor, I remember you saying that he should do the surgery as soon as possible, but we decided not to do it based on that and that. Eventually, we may need a transplant in one of the eyes, but eventually we may even say it's not worth because his patient is doing his activities normally. So it may not be the best thing for the patient. You don't, the patient with 100K max.
Yeah.
It's
100.
you're not treating the 100K max. You're treating a human being that has a disease and the family and everybody together. So you have to be considering the pros and cons always and make a decision based on what you think is best. Sometimes you're not correct. Sometimes you're wrong. Sometimes you are understanding that you should have done, but you have not done. But you have to be uh, keen and honest with yourself to get better at, like, think artificial intelligence. Keep getting better and keep making your decisions more effective and more correct based on the best as possible that you can have.
Yes, sir. The first thing to correct the base of the problem, the basic reasons for the problem. And you think, sir, from your answer, and if I correct the environmental factors, if I correct the mechanical factors, the habits, and educate my patient, and when I fight the allergic conjunctivitis itself, this will make the condition stable or stationary, at least, right?
Yes,
And then after correction of all factors, I can judge later for the ectasia if in need for the cross-linking or not.
absolutely, yes.
Right?
Sometimes you say, I would have this patient going back to his CT, which is 500 kilometers from my town. It would be hard for him to come back in next year. I would say, let's do cross-linking. And now you have an information and a factor to make a decision. And eventually that can level your judgment for making a decision for doing more or doing less according to the case.
Okay,
And share that information with the parent.
but there's no definite age. You can do cross-linking in a patient who is less than 10 years if needed, and even if more than 50 years too.
I have done cross-linking in older people, and some of them they do very well. I have done cross-linking in many kids. One situation that I would always remember people to think about is that if the patient has less than 7 years old, some of these kids they come, and amblyopia should be considered. So you have to think about everything you think about keratoconus, and also patch the good eye, and not patch with pressure, because and these patients they may have a more urgent care they need to, because of the amblyopia that can be deeply developed. Eventually they will have amblyopia anyway at some level,
Yes.
but you have another factor to be considered.
Yes, sir. Okay. Do you have a time? I wish not to exhaust you. You have a time?
No, I think we can get more 8 more minutes so that we complete. It will be like almost 2 hours. I think people would not be enough to 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 tire people to listen to us. We should, but we have 8 more minutes. Let's finish at 4 o'clock.
Okay, they will listen.
My time.
Sure, but I may cut it in many in a series of
Oh,
yeah in series, not to be long for them, showing subjects with a discussion about it. I will edit this videos.
great.
Yeah, but
Send it to me
actually
too.
the talking to you is very interesting, and then and it's a fortune. Uh, uh, and really a good chance for me to learn. And you are teaching the word now, and especially you are a very good teacher and a very patient teacher.
Thank you.
Okay, what about the topography alone? You can judge. You mentioned the first slide. You can judge with your patient using just topography, or you have to combine the elevations with the bathymetry to get a final decision about your patient. If you have inferior steepening in the topography with very good bathymetric curves and indices, and also you have a very good within normal anterior and posterior elevations, will you consider this patient as an ectatic condition?
Um, Probably not. Uh,
Yes.
two two things: facts and opinions. Facts are things that we should not debate. It's a fact. We should acknowledge and understand. Opinion we can change eventually, but the fact should not be changed. Eventually, changing a fact it makes the point that it's not a fact.
Yeah.
But the fact is, topography is sensitive to detect abnormalities in patients with normal slit lamp and normal vision. So it gives you a step forward in sensitivity. It's also a fact that topography is not the ultimate most sensitive diagnostic feature. We have sensitivity and specificity. In many cases with abnormal topography, with mild cases, especially the ones that were considered like keratoconus suspects, and eventually some of them that have enough abnormality to say this is the criteria for the KC, that may be a false positive on topography.
Yes.
Again, as much as we know that we need to know more.
Yeah.
If people would say differently sometimes, as much as I know, as much as I know that I don't know. No, I don't like that. I think this is crazy. This
Yeah.
is very bad. This is mediocrity.
Yeah.
The good thing is, as much as I know that I need to know more. So if I know about that, I need to know more about the corneal shape. And again, biomechanics is important, but epithelial thickness comes as a very important point. Dan Reinstein has a very good paper on JRS,
Yeah.
which he describes patients that had LASIK with stable outcomes that had abnormal topography, but he said, yes, you can do surgery based on my epithelial thickness profile, and he did surgery. And these patients are normal and stable in the follow-up. So it's an enhancing specificity issue that we can do with advanced imaging, which not necessarily only on topography and biomechanics and tomography, but goes to the epithelial thickness, which I like to call as segmental thickness, which goes to the ultrasound and OCT. We did not have time to discuss about that, but I do OCT in every patient. And the thick epithelium in the area that you have the protrusion, it means that it's not an ectatic cornea, it's a abnormal shape, is a warp on the surface that is related to the epithelial thickness. However, it's not easy because some cases are mixed. And again, if you have mixed data, you're not so clear, you should not do the cut, considering LASIK candidacy. But going back to your question, should I do laser vision correction only based on topography, which I understood that was where you're heading to with your question. And I think I started doing that. You know, if in 1999 when I started doing LASIK, I was doing it based on central corneal thickness and placido disc topography. So
Yes.
if I would say,
yes, I'm too.
that's a wrong thing, you know, I'm putting myself in jail.
Yeah.
So I think when and where.
Yeah.
When 1999 in Sao Paulo, in 2000 in Seattle, Washington, United States, that was the gold standard. The problem is that the gold standard is not like a decree from the president. So the Constitution says we don't have that. We have literature, we have peer-reviewed literature, we have evidence-based medicine.
Yes.
And when topography is not enough, or even if topography is not enough, is something that we should debate on.
Yeah.
Again, make a decision based on what you believe. And Saint Augustine, he
But
defines.
I want to add at some point. This is part of my question. The other question, if you have all these tools and find some abnormality in the topography, yeah, okay, I have already started my LASIK work in 2007, where in my governorate, there's no pentacam, just the Tommy topographer, just the topography, and we had measured, we're measuring the corneal thickness by the pen pachymeter, like the ultrasonic pachymeter. Okay, but nowadays, if I have a pentacam, the 4 composite map, and I have some topography suspicious points, but normal anterior elevation, posterior elevation, and pachymetry. Can I ignore this topographic findings or not? This is a question.
I would not say you should ignore it, but you should consider this is something less important. I would say don't ignore it. Ignore would be wrong, but judging it and balancing it out according to the other data, it's correct. But I would say I have seen cases in retrospective studies that they taught us a lot. And those cases, they were patients that had LASIK with stable follow-ups and patients that have a normal topography.
Yes.
And we had a huge selection and attention to those cases. And those cases, they teach us, but when is enough to follow up the patient to say that they did not develop ectasia? I have seen a patient, a physician that had ectasia 13 years after LASIK, 13 years. So let's wait 13 years.
13 years?
13 years after
13 years, yes.
So and she started with a normal topography. Even I have a patient that I did LASIK with a normal topography and he's stable.
Yes.
For how long? For 1 year, not enough. 2 years, not enough. 5 years, okay. Is it enough?
Yeah.
You know, for every years. So I would say balance it out. That's why I believe it's important to say that we have to go beyond, not over topography, but beyond. Some controversial aspects will be coming with, I don't look at that data. I look at every data, but I judge the data more or less accordingly to the presentation of the patient. So age will be important, thickness of the cornea will be important, back elevation will be considered more or less based on that. But again,
Okay.
the main information is coming from, in my opinion today, the most accurate parameter in my judgment is the TBI. And I look at TBI, and then I look at the epithelial thickness, and I look at the wavefront.
Yeah,
That's how I look at how I do my routine.
yeah. I just wanted to add this point and to send this patient for the corneal hysteresis and help you judging this patient's susceptibility
Yeah,
and the
yeah.
suitability for the
Send,
refractive surgery. Yeah.
if you send me the UTRL files from the Pentacam, I can calculate the PRFI. The PRFI is much better from the biomechanical, without the biomechanical data, just from tomography, just
Yeah.
the PRFI can be better than the BAD.
Very far, yes.
And I hope we have that soon in our displays.
Yes. Second question. Sorry for for
Good.
long time. The posterior elevation. If you have a problem in the posterior elevation, just but every other things are okay. Do you think that there is what's called the posterior keratoconus?
Hmm. Posterior keratoconus is a misleading term.
Is a fact or not?
The No, it's a misleading. The term is misleading because in old textbooks you see posterior keratoconus as a as a different thing. It's a condition in young patients that it's not related to what we're talking today in an adult patient. If you see posterior keratoconus is different, but a patient with an abnormal posterior elevation likely would have abnormal tomography and biomechanics. But you have to judge. Uh, Looking at the data that we have, I would say that uh, in more statistical factor, we have about 15% of patients with abnormal posterior elevation, defined by highest elevation higher than 15 microns at the thinnest point using 8 millimeters best fit sphere.
Yeah.
I would say we'll have 12 to 15% of false positives based on that, on normals. And those are normals. And if you look at these patients, the majority would have a normal biomechanics, one or the another. So I would say it's not the most sensitive and not most specific parameter.
Yes.
Elevation is important, is a factor that we combine, but it's not one parameter that gives you. But again, judge everybody together, every factor together to make a decision.
Yes.
But it's possible to have abnormal topography with a not ectatic cornea. It's possible to have irregular back surface with not ectatic cornea. Yes, yes.
Okay, but we cannot call it all the time as a posterior keratoconus, which is an indicator for the coming anterior keratoconus. I mean that the cornea
Uh,
is a one unit. The cornea.
you can
Yeah.
call, but you know, we are speaking English here. If I start speaking Portuguese, you wouldn't understand anything. You speak Arabic, I wouldn't say anything either. So we won't be able to communicate.
Yeah.
So we try to speak the same language,
Yes.
and we try to define the terms so that we agree in what we're talking about. I try to define form fruit keratoconus, which is something that was much more commonly used than the posterior keratoconus. There
Yes.
is no consensus. So if I talk about posterior keratoconus, a lot of people have different feelings and different understandings about it. And a puristic guy, academic guy, that would say, no, no, look at this textbook. Posterior keratoconus is different. If you see the literature, there are papers on posterior keratoconus that are nothing related to abnormal tomography shaped corneas. So I would say that's not a good term. But again, it's not a fact, it's an opinion. A fact is They are normal corneas with about irregular posterior elevation. Yes, that's a fact.
Okay, does astigmatism make a false posterior elevation, false abnormal posterior elevation?
Yes, depending on the diameter of the cornea.
Yes.
One of the factors, two factors that are coming very important is the anterior chamber depth
Yeah.
and the white.
Yes.
This is important.
Okay. You have ever seen? I will let you to go to your daughter, but do you have ever seen the superior keratoconus or what's called inverted keratoconus?
Superior keratoconus, yes. I would not say keratoconus, but superior ectasia, yes. We have seen two cases.
Superior
So it's
is
very
not
rare.
keratoconus.
Yes.
Yeah.
So, you know, if you turn it on, it's a keratoconus perfect. But actually, will be, and these two cases they have interesting aspects. One of them is a very symmetric ectasia case with abnormal tomography and biomechanics in the fellow eye, and he has a very nice band of thinning. And it's not a terrien,
Yes.
not a Mobius terrien. It's not, and it's not other situations like inflammatory like Murine ulcer. It's a pure non-acute inflammation because probably there are some inflammation happening in the tissue, but not acute, not obvious red inflamed cornea in the patient that has thinning. It's a superior thinning, a superior band of thinning, and I cannot explain that. I have seen it, and there are some other cases in the literature. In those cases, they are very much at risk for rupture, for not spontaneous, but rupture with minor trauma.
Yeah. Yeah. Okay. We have an endemic disease here in Egypt, which is the trachoma. Trachoma,
Yeah,
which causes superior thinning, superior pannus of the cornea, and the subepithelial fibrosis. So we are referring the superior thinning or superior steepening in the corneas here to that disease. So I'm not believing in the
sometimes
superior keratoconus.
I know exactly what you're talking about when I think about both Nobisteyan and Murins also. We have trachoma in Brazil too. We have
Yeah.
the art line and the herbs.
But,
This is not those cases. These are pure, beautiful limbus,
yeah.
normal tarsus, thinning of the peripheral superior cornea.
Yeah. Okay. The first question about indifferent language in cases of post-LASIK ectasia. We are agreed now. We are agreeing each other now about the keratoconus, the cross-linking, and I'm the judge in that about my patient's situation, my patient's mind, and social class, social and educational class. But about the post-LASIK ectasia, if I catch it, a patient with post-LASIK ectasia, which is advanced in one eye, well apparent in one eye, but the other eye is still within the accepted images. Will I do cross-linking for both or for the advancing one? Both ectasia, not the keratoconus.
Yes, I look at two things. I try to look at the pre-op data.
Yeah.
I try to see the flap thickness
Yes.
and make a decision based on that. If the patient is seeing well in that eye, I would say be careful on indicating it. If the patient is losing lines, you should do as soon as possible, no question. But again, those post LASIK ectasia cases, I would say they are more, they need more surgery than keratoconus. They not more. I would say they did differently the surgery because the likelihood of progression is is not related to age as in keratoconus. So it's important to consider that.
Yeah. 6 months ago, I was a chairperson in a session. Michael Pellin was a speaker in it. And I have asked him a question about the posterior surface of the cornea is changed after LASIK surgery or ablative procedures or not? I couldn't get the answer from him, so I'm asking you this question now.
Well,
The back surface changes after LASIK surgery. If I got a case of ectasia and I backed to the preoperative elevation, posterior elevation, to compare it with the posterior elevation after LASIK, after surgery on presentation. Uh, can I say that the back surface is not changed at all after surgery, after LASIK surgery, even in the normal one? Even
well, this is,
I mean a stable one, not ectatic cornea.
uh, I look at the posterior elevation. You have to look at the same best fit sphere reference.
Yes,
Just right click in the first one and have the same reference.
yes,
And I look at that as one of the parameters. If it's more than 7 microns, I would say this is something that I have to take in consideration. I had my first ectasia, by the way. And when I look in retrospect, for that case, I think I should have done something much before. The surgery was in 14.
yes,
When I saw the patient in 16, patient was 20/20 uncorrected with a huge change in the back surface that I didn't recognize.
yeah,
And
okay,
then she comes back later, years later, with much worse vision, now 2100 uncorrected vision. And I should have done it before. But
yeah,
I start looking at the back surface elevation of many cases that are doing very well, and I don't want to create a panic to treat with cross-linking many stable cases. So you have to use that in your decision making, but I wouldn't recognize the value of do it in everybody if just with creating a rule of that. But it's something that we have to be very much in favor. Actually, one of the first Pentacam papers that made a point on the benefit and importance of that was related to the back surface change,
yes,
which was very minor considering the other reports from the orb scan, for example. It's something. And I think even in the Pentacam, some of the back surface elevation that we are picking may be noise, but it's definitely much less than in the orb scan 2, for example. Probably the new machines are getting better on that because they have recognized the ray tracing issue and all the the possibilities to improve the algorithms for the calculation of the back surface.
uh,
Well,
okay.
let's,
Okay. So, what is the thinnest location or the thinnest location value from which you can cut? You can go for flap.
uh, I don't, I think with a femtosecond laser, you can cut a flap of 90 microns in a patient that has 480, 490. But I would say don't be a hero in refractive surgery. Go for PRK, surface ablation, and eventually phakic IOL. I
Okay,
would say,
but if you have a patient with the thinnest location of 480 or 190 with with a small error, the TPI, the PTA still less than 35%. Can you go for LASIK surgery or go for PRK?
PRK.
Great question. It's it's the daily question everywhere. You know, the daily questions
I,
from the young and the big ophthalmologists everywhere.
I know that. I have these questions too, and you can, but you should not.
Yeah.
Maybe you can, but you should not.
Okay, but
Well,
the
we
safe zone is 500 or which one?
I I like to leave 300 microns of residual stromal bed plus, and eventually I don't take much of attention on the PTA, but I think it's very important not to go much higher than 0.45. 0.4 maybe not so
We
sensitive.
are at risk now. Of 0.4, we are going to the risk 100%, as Marconi said. Marconi Santiago said
If
40%
if you
more.
if you see, I'm looking at the slide here now. If you see my slide on the study that we have, I will share this screen with you. Um, this is a very compelling data. You see, if you use the 40%, the sensitivity to detect the 105 cases of ectasia would be 25%. And
Yeah.
you will not do surgery in 88.2%, in about 12%, 11.8%. So I
Uh,
would say
When you,
this is not good, the sensitivity. So
yeah,
the majority of cases, in this population, the residual strong beta 300 was better than the PTA. But this is based on tomography, and the PTA is very good if you just think about central cornea thickness. And the uh, PTA is a good thing it's based on the impact from surgery.
yeah,
But if you have a thick flap, if you have, for example, a thick flap and a very little ablation, and a very thin flap and a lot of ablation, it may have the same PTA with a different impact on the cornea. So that's why I believe PTA is important, but should not be a golden rule. It's as Marconi just is emphasizing now, is one of the important parameters to be considered, but it's not a screening factor. It's not yes or no, but everybody takes it as a yes or no because people want to have easy answers. Well, I think we have to finish because we are
yes, we have.
at,
We have to finish. We are here at the darkness, at the night, and you are still having the sun. I see the sun from the windows.
I
Yeah,
have some sun.
but it's a good
It's a
perspective.
beautiful day.
It's a good
We
perspective.
have been
Yeah,
we are here in house for over a week now, so
yeah.
yes, but
It's
it's good to see you
it's
in
it's
Egypt, and it's
it's
great. We
it's
never
like
had that opportunity to do that.
it's like a good prison. uh, may the God recover the word from all of that. But it's a good perspective from you. I heard now just about the flap thickness. We can go deep with the same BTI, and we can be superficial ablation with the same BTA. But regarding the corneal affection of the tensile strength of the cornea is totally different. So I'm liking the thin flap. I'm going for 90 micron film to flap as I got. So I will leave the remaining questions for the next meeting.
Let's plan it. Let's get this rain check. Let's do it again. It was very nice talking to you. You
Uh,
were great. You are
yeah,
great, uh, enthusiastic, and you have the right questions.
uh,
Write these questions to me, and then I can prepare something to you.
okay, okay. And really, I cannot express my thanking and appreciation to you for your time and for your knowledge. But uh, nothing, just may Allah bless you and your mind and your work and your family and everything. And
Thank you.
we will do it again, sure. Please, if you allow, if you permit.
I do. Please promote the International Society of Refractive Surgery, the ISRS, in your area. We have excellent contents. Pretty much all that I just said is diluted in the online webinars and things that we have done. Maybe a good resource for information uh, in this time that we are at home.
Yeah. Okay. I wished at the start to say, but you started speech immediately to say congratulations for the presidents of the
I,
IRSR, right? International Society, ISRS,
yes,
International Society of Refractive Surgery. Hoping the best for you, and really the congratulations for the society itself by your by being the president. And I hope
thank
to
you.
be a member in this society and the sharing with the work and the experience.
Thank you. You are very welcome to join us. Thank
Okay,
you.
thank you very much.
Okay,
Bye bye.
goodbye. best for you and your family.
Okay, thank you.
Bye-bye.
And you too. Bye bye. Bye bye, Renato.